I'd like to thank the organizers for the invitation. I thought it's been a really excellent set of presentations this morning. I've learned quite a bit. I also learned on Thursday that I had submitted the wrong title with my slides to the organizers a month ago. So I fixed the slide. Not just going to be speaking about HER3. And I do have conflicts of interest. The work I'll be presenting today is covered by intellectual property, and we have a memorandum of understanding requiring disclosure. The first part of the talk relates to HER3 targeted therapy for pancreatic cancer. But I have to give you some background. We've heard a little bit today about EGFR, or ERB1, or HER1, all the same. There's also HER2, HER3, and even HER4. And these are growth factor receptors that are expressed on pancreatic cancer. And there was a hope at one time that one could use an epidermal growth factor receptor inhibitor to prevent the proliferation of these pancreatic cancer cells. And it turns out that, and this has been known for some time, that there's a heterodimerization that occurs, for example, between HER1 and HER2. And so you can't just block HER1 and expect to inhibit proliferation, because you can still get dimerization. You can't block HER2. And recently, and it's been known in recent times that HER3 is also involved in heterodimerization. And people have started to develop HER3 antibodies, but I'm going to tell you about a new type of HER3 antibody. Now, these slides are strange. So back when I started working with EGF receptor antibodies, John Mendelsohn had produced an antibody that was originally called C225, or ERBITUX. That later, when it received approval by the FDA, was named cetuximab. And the properties of this particular antibody, that it binds to the EGF receptor with the same affinity as the native ligand, epidermal growth factor. It blocks the binding of EGF, and therefore potentially could be therapeutic. It inhibits EGF and TGF-alpha-induced activation of the receptor tyrosine kinase that provides the signal for proliferation, and it also undergoes internalization on binding. I was telling this story last night that my original work in this area was oriented towards the treatment of head and neck cancer. And we had treated a group of animals with the 225 antibody with radiation, and we actually produced cures of the animals that were treated in that way, and the antibody itself didn't do that, and it didn't do it in combination with radiation. And I had met Selwyn Vickers around about 15 years ago, a surgeon at UAB, and he told me I should really be working with a real cancer. The work I was doing on breast cancer there were therapies available, nothing really available for pancreatic cancer. So I carried out, I forget which is the pointer is there. Where's the pointer on this thing? Where's that? Must be that one right there. Okay, I got it. So this was a groups of animals that had tumors established subcutaneously. And we'll ignore all the groups that showed growth, progressive growth after treatment. Just focus on the two lines down here. The first group, the purple, was the antibody plus radiation, which produced a marked regression in tumors, prolonged inhibition of growth, followed by regrowth. There are 10 animals per group. The group that was treated with the antibody and chemoradiation, gemcitabine with pre-grade radiation, showed long-term total inhibition of growth. That looked very much like what we had seen in head and neck cancer. Head and neck cancer story resulted in a phase 1 trial with this antibody, and ultimately a phase 3 worldwide trial. Approval due to the fact that there was a significant reduction in local recurrence and significant extension in overall survival of patients being treated with head and neck cancer with this antibody and radiation. And Giovanna led those studies at UAB. So when we produced this, I said, great, we've got something that could be used for the treatment of locally advanced pancreatic cancer, as we heard in the previous talk. Maybe we could convert some of those patients to the point where they would be resectable. Well, in fact, it didn't work. There were about a dozen patients treated with the now cetuximab and gemcitabine and radiation, and it led to no patients undergoing surgical resection, so a failure. And this was part of our Specialized Center of Research Excellence in Pancreatic Cancer, one of the trials that was conducted in this particular project. And complicated. Years later, they came to the same conclusion that I did, that in patients with advanced pancreatic cancer, the anti-EGFR receptor monoclonal antibody, cetuximab, did not improve the outcome compared with patients treated with gemcitabine alone. Other therapies other than EGFR should be evaluated for new drug treatment in patients with pancreatic cancer. This is published in 2010, I believe. Well, I had already made that decision as well, and so we moved into a new area. And that was looking at the use of what are called death receptor antibodies. And it was work, again, in the same project within this sport program. This was work that was started with Al Abulio as the clinical co-leader. And there was an investigator at UAB who had produced an antibody against one of the trail death receptors. Now, you may know about the TNF receptor superfamily. When TNF was first discovered, it was thought that it would be the magic bullet, that if it could be administered to a patient safely, it was capable of really producing necrosis in tumors. However, it produced a lot of normal tissue toxicity and was abandoned. The second member of the family, the Fas ligand, and an antibody that bound to it, likewise produced toxicity when administered to humans and to non-human primates. And then two investigators discovered a third member of the family, TRAIL, which actually has two death receptors, DR4 and DR5. There are also decoy receptors these are receptors that are not natively expressed on our cells, and TRAIL, the native ligand, does circulate in our bodies, but the decoy receptors do not produce toxicity upon binding by the ligand. Dr. Tang Zhou in the Division of Clinical Immunology at UAB produced the first monoclonal antibody against death receptor 5. And that then led to a series of studies in collaboration. Moreover, in addition to the extrinsic pathway for the induction of apoptosis upon binding by either TRAIL, the native ligand, or an antagonistic antibody to DR5, which is what we were investigating. Once that binds to the extracellular receptor, it induces a death-inducing signaling complex and resulting in apoptosis. But it was also known that combination treatment with either chemotherapy and radiotherapy acting through the p53 pathway would actually be capable of producing synergistic cytotoxicity. So we pursued studies to investigate this combined modality treatment. I'm not going to show all the results. The first paper on the antibody was published in 2001. The interaction with gemcitabine against pancreatic cancer cell lines was published in 2007. Also, in that same paper was evidence of growth inhibition, extended survival of animal models treated with the combined modality. The antibody was licensed to a Japanese pharmaceutical company. They humanized it, and they showed that it had activity against xenografts, as had the original murine antibody. A phase 1 clinical trial was conducted at UAB. There was no dose-limiting toxicity. A number of patients showed stable disease. So this became a phase 2 trial in our project in the SPORE. And 61 patients with newly diagnosed unresectable or metastatic pancreatic cancer were treated with the combination of gemcitabine and the antibody now labeled, the humanized antibody, trastuzumab. Again, not a successful outcome. Pancreatic cancer is quite a difficult disease to treat, as you all know. The results were that there were no complete responses. There were 13% partial responses, 13% objective responses, 45% stable disease, and 23% progressive disease. Kaplan-Meier's plot for progression-free survival or for overall survival look as if the patients weren't treated, basically. Or the equivalent of getting gemcitabine. So again, Tang Zhou, thinking about the whole issue years in advance, he was always worried about resistance mechanisms. You know that many patients become resistant, or their tumors become resistant to treatment with chemotherapy. And he was worried that even with this apoptosis-inducing antibody, that you may well end up in a resistance situation. And how do you overcome that? Even combined modality treatment ultimately would not continue to be successful. And so he thought, well, maybe we could come up with another enhancing antibody that overcomes the resistance. And we knew that amongst even panel of cell lines, there are some that are sensitive to the apoptosis induction by this anti-DR5 antibody, and there's some resistant. And the levels of the apoptosis regulating proteins within a cell vary amongst different cells. So it's a very heterogeneous situation. So what he chose to do was to immunize mice with a resistant, a DR5 resistant cell line, not sensitive to the death receptor 5 antibody. And he then screened clones of antibodies that were produced and looked at whether or not they enhanced the level of cytotoxicity of the DR5 antibody, and then it did a proteomic analysis to determine what type of antibody actually was enhancing the level of cytotoxicity of the DR5 antibody, and lo and behold, it was an anti-HER3 antibody. And it was shown in vitro that the antibody bound to HER3 here and here, but did not bind to HER2 or EGFR. So he had a specific antibody for HER3. In addition, he took purified HER3 and immunized mice and produced a second antibody that likewise was specific for HER3 and not EGFR or HER2. So there are two different antibodies, 1A5 and 3D4. And upon further analysis, it was shown, and it was a little hard to figure out how to get this big enough so you could see it. It's in your handout. This is phosphoryl. I'm looking at this line right here. This is phosphorylated HER3, and the 1A5 antibody was able to reduce the levels of HER3 phosphorylation in a ligand-independent fashion. Whereas when cells were stimulated with neuregulin, the 3D4 antibody could reduce the levels of phosphorylated HER3 as well as the 1A5 antibody. So he identified two classes of HER3 antibody, one that is ligand-dependent in terms of its activity and one that's ligand-independent in terms of its activity. And so the hypothesis of going forward from this point was that the activation of HER3 via both the ligand-dependent and independent pathway is critically involved in the development of resistance to EGFR, and also PI3 kinase and MEK-targeted therapies. And the blockade of these pathways, particularly the ligand-independent pathway, in combination with EGFR and or MEK inhibitors, would be an effective strategy. That is, one has to not only knock out HER3, maybe, keep both the ligand-dependent and independent, because any activity that's left over is going to stimulate proliferation on exposure to EGF. And so one has to think in terms of all the pathways that are involved in and related to EGFR. It's pretty complex. It may be beyond reality that this will actually ultimately be implemented as a mechanism of treatment, but it's certainly worth making that determination. And so the schematic just gives you an idea that we're targeting now in what I'm going to present, not only EGFR, but MEK and HER3. So these are a panel of pancreatic cancer cell lines here, and this is their AKT expression, and they all express, and phosphorylated ERK, they all express. Erlotinib, the EGFR inhibitor, had minimal reduction in activity of AKT, minimal effect, no effect on ERK. Trametinib, which is a MEK inhibitor, likewise not much of an effect. And then the combination of erlotinib and trametinib had some reduction in some of the cell lines, levels of AKT, as well as either alone trametinib, reduced ERK, that's just one of its targets, as well as in combination with erlotinib, reduced the level of expression. In addition, not going forward now. Oh, press it over. In looking by Western blot for expression of EGFR and HER3, total EGFR amongst the panel of pancreatic cancer cell lines, once again, they all express EGFR. That's why it would really potentially be a good target. It's expressed in greater than 90% of pancreatic cancers. HER3 is expressed in most. Phosphorylated EGFR in the panel, phosphorylated HER3. So the targets are there. And then looking at, and I gave you EGFR and HER2 in the handout, to make it simpler, just focusing on HER3, phosphorylated HER3, that if in fact these cell lines are exposed to neuregulin, you see an increase in phosphorylated HER3. And if you treat with lapatinib, or let's say first the 1A5 anti-HER3 ligand-independent antibody, lapatinib or erlotinib, you have minimal reduction in phosphorylated HER3 activity. However, if one treats with the combination of the ligand-dependent and independent antibodies, you enhance the level of effect. And this is looking at proliferation. And for example, if you treat the cells, the cell line with erlotinib, you see a reduction in proliferation. Erlotinib binds to EGFR. If you treat with lapatinib, that binds to EGFR and HER2, slightly more inhibition of proliferation. But if you expose them to the 1A5 HER3 independent antibody, you reduce proliferation even further. And if you expose them to the 3D4, not much reduction. The combination of the two HER3 antibodies is a little bit better. In combination with Lapatinib a little bit better, and a somewhat improved anti-proliferative effect when you treat with the two antibodies in combination with Lapatinib or Erlotinib in that cell line. So we did some pilot animal model studies just to get a sense, can you translate any of these effects of cells in culture, which are easy to treat, and get delivery of these small molecules or antibodies to the tumor, as well as in combination with small molecule inhibitors. And this illustrates treatment of a Miyapaka orthotopic model implanted in the pancreas. And here's what happens with no treatment, so survival. If you treat with gemcitabine, this model, this cell line is not very sensitive to gemcitabine, minor extension in survival. If you treat with the combination of the two antibodies, you get an enhanced survival. And if you add gemcitabine to that, no further effect. Now, it turns out, even in the animal model, these are fairly significant extensions in survival. Whether or not they would correlate with any extension in the human, I wouldn't want to even make the guess. Here's looking at a Trametinib, a ERK inhibitor, MEK-ERK inhibitor, this Ph.D. compound. And you see once again Lapatinib or Lapatinib plus two HER3 antibodies, or the combination with the MEK inhibitor, once again, you're getting an enhanced response. If you treat with the Abraxane and HER3, you get some improvement in survival, or here versus gemcitabine and HER3. And most recently, we've put it all together, and one sees that the lower set of lines, so we do get a distinction in response, and not as much of an effect as we'd like to see, but nevertheless, it's clear that if one uses the HER3 antibodies with Trametinib, and with gemcitabine, you get the greatest reduction in tumor growth. And this is a repeat study where we use cetuximab in combination with the HER3 antibody, Trametinib, and gemcitabine. And again, this is an ongoing experiment. Now, the one last thing I can say, and I don't know that it's going to lead to anything, is that Daiichi Sankyo has now produced an improved anti-DR5 antibody that has a higher affinity and greater efficacy in animal model studies. A phase 1 trial, which includes UAV, will be opening in the next few months. And so one could ultimately think in terms of the potential of combining this new and better anti-DR5 antibody with anti-HER3 treatment as well. So I'm going to stop there. Do I have a minute left? Can't tell. So in conclusion, I would say that, number one, this recalcitrant tumor is really, that's the case. There's no question about it. One of the problems could well be the inability for early detection. So in general, patients are being identified that have locally advanced disease or metastatic disease. In addition, which was not discussed in the previous presentation, there's a desmoplastic reaction that occurs, a fibrotic inflammation that occurs that may well be preventing the delivery not only of monoclonal antibodies, but even of chemotherapy drugs and small molecule tyrosine kinase inhibitors. Whether or not that's as difficult a problem in metastatic disease, I'm not certain, but it's certainly an issue in regard to the primary site. With regard to the HER3, I think that we've demonstrated that there are two types of HER3 antibodies, and provides an opportunity for us to further investigate this type of enhancing antibody, not only with cetuximab, but also with a death receptor-inducing antibody. And it's even more complicated than that because you have feedback pathways that regulate the expression of MEK and ERK, which enhance the level of HER3 activity. You want to block that, so you need a MEK and ERK inhibitor as well. So it's quite complicated, but it's a path that provides an opportunity for this lab, the bedside, back to lab type of activity, which is what this program is all about. I'll be happy to entertain any questions.